No, thanks, Jens. Thank you and Rod for inviting me to give this presentation. And it's like you always look for the guy that's got to follow failings to give a talk about anything spinal cord injury. So this is tough to follow. Honored to give this talk. I'm going to talk about central cord syndrome and look at sort of management and issues in 2024. Here are my disclosures, and none are relative, obviously, to this presentation. But let's start with a case, right? Because central cord syndrome and injury is common. We all see this in our practices, in our ER, and we all see the issues that we face. So this is a 68-year-old woman, true case, came in after a post-syncopal ground level fall, came in the emergency room complaining of bilateral hand tingling, and really difficult grasping the hand of the person who was trying to help her up after she fell. She notes that her symptoms are stable. She's about grade motor 4 out of 5 in her hands. She's got decreased dexterity to finger tapping. She complains of paresthesias, but her gait is normal, right? So a classic central cord type patient. But her blood sugar is 400. She's a type 1 diabetic, poorly controlled. She has high blood pressure. She's got some renal failure. She has severe depression, anxiety, and she's obese. And she's had a prior C5 to 7 ACDF, right? And that is what we're seeing now today with our spinal cord injured patients. And you look at her MRI, and she's got, you see the prior prior surgery. She's got spondylosis and, the stenosis at this C4-5 level, right? And that's our patient, right? How do we manage this patient today? What do we do for this patient? Timing, surgery, type of surgery, et cetera. So as Michael just talked about much more eloquently than I can, is we've seen a pretty significant shift in the demographics of spinal cord injury, right? And in the past, it's typically a young male doing high-risk activities, driving fast, drinking and driving, right? It's a fracture dislocation. It's a complete spinal cord injury or a high-level AGES score, right? And now we're seeing many more elderly patients, a low-energy fall. They have no fracture. It's an intact spine to spondylosis, and they have an incomplete spinal cord injury, right? This is now what we're seeing here. And as our population continues to grow and age, this is going to be much more common, and we've got to understand this problem and the differences, difficulties with it, and understanding the management of it moving forward. Now, Schneider described this injury in 1954 and did a nice job describing it, but I think has done a disservice to us in the spine community from that literature and us carrying it forward, right? So he described this as a disproportionately more motor impairment in the upper extremities than the lower. There's bladder dysfunction, usually urinary retention, and a varying degree of sensory loss below the lesion, right? He hypothesized there's buckling of the ligamentum flavum. You would get this sort of central hematoma or hemorrhage in the gray matter of the spinal cord. And as it spread, you would get damage to the somatotopically more medialized hand function in the cortical spinal tract, right? And that is really what we thought and what we taught, right? And that was what I was taught when I was in training. And in fact, we say this today. We just presented a central cord in our resident conference 2 Wednesdays ago. 2 Wednesdays ago, one of my senior partners got up and asked the resident, why is the hands worse than the arm? And he gave the classic Snyder definition of that, right? But the issue here is we know that that's now been disproven, right? That's not true. We know that from imaging studies, autopsy studies, and animal sectioning experiments that really there is no central hemorrhage in central cord syndrome, right? It's lateral white matter damage. And with lesioning experiments, we know now that the cortical spinal tracts are much more important for hand function and not so important for locomotion, right? So this is the reason we see more hand function. It's not that central hemorrhage. It's really more of a lateral white matter issue, and it's predominantly affecting the impact of the cortical spinal tracts to the hands. Now, where was the disservice with that original publication is that Snyder said, look, these patients get better, right? They have a favorable course if we treat them with surgery or without. And in fact, surgery had a worse outcome, right? These patients did worse, and we ought to not do this because we're going to make them even be worse. Now, what were they doing back then? They were doing a laminectomy, a durotomy, section to dentate, trying to get discs from the front of the spine through the back, right? These patients you would just predict would do worse. But this is carried on into the modern era. Now, I think a lot of people obviously have changed their practice. A lot of work by Fillings and Jens and others have changed the way we look at this. However, this does persist today where people are saying, look, we treat these patients conservatively and we're not going to operate on them because they look back at this literature. But in fact, when you look at the evidence, these patients probably recover no different than other patients with spinal cord injury, right? The other thing that's important here is that, in fact, surgery is not more dangerous when we do it less than 24 hours, right? It's shown to be safe and effective, not just in spinal cord injury patients like Michael just talked about, but also in subsets of patients that have central cord syndrome. So we don't make those patients typically worse if we take them to surgery somewhat quickly. The other issue here is that when we think about central cord syndrome, we often think about it's this sort of homogeneous patient population, right? It's hands more than legs, it's elderly, low energy fall. They're all the same, right? But in fact, it's very heterogeneous, right? These patients have varying degrees of motor, sensory, and neurological impairment. And there's different causes of this, right? So you can have a low energy fall, an intact spine with a central cord. You can have a fracture dislocation with a central cord. You can have a disc herniation with a central cord. They're all presenting the same neurologically, but have different etiologies, pathophysiology, but they have different ages. The issue is, do we treat these the same? Is it the same in our mind on how we approach them, right? So on the left, we've got a 79-year-old woman. She fell from standing. She comes in the ER with paresthesias in her hands. Her hand grip's about 3 out of 5. Her gait is normal. The image on the right is a 29-year-old with an MVA with an acute disc herniation. You see the signal in the cord, paresthesias in the hands, and hand motor 3 out of 5 with normal gait. So they have similar neurological function. So they're both central cords by definition, right? But do we treat them differently? Do we approach them differently? And I would say the answer is yes. And perhaps that's where we've got to switch our mentality here going forward and maybe manage them similarly. But we've got to consider other issues as well, as we'll get into. So natural history thought that these patients universally recover without surgery. We know that that's not necessarily true. They recover probably very similar in ways that other patients with spinal cord injuries, other than central cord injury as well. And we've got to factor in prognostic issues that we know about, like what impacts recovery from a spinal cord injury. Well, one of the most important issues is the initial neurological presentation, right? And many of these are low energy falls. So they come in with, say, an ASIA D, and those patients theoretically should improve better than a C or a B or an A, right? So they are going to improve better, but maybe it's not because they're central cord. It's just because they have a much more mild incomplete spinal cord injury, and doesn't mean we should manage them any different than perhaps another type of patient. And those that have an ASIA C, perhaps with a central cord and elderly, a low energy fall, we should probably treat them in a similar way as we would with someone with a fracture dislocation with an ASIA C as well, right? They don't do any different. We should probably manage them in a very similar way. So I think when we see these patients, we've got to give a number of considerations for them. In particular, one is their initial presentation. Many times you see these patients in the emergency room or the trauma bay, and they're improving in front of you, right? They came in with a neurological deficit, it's getting better. How do we factor that into a timing of surgery, or do we operate on them? Are they deteriorating? Of course, that may change what we do. Have they plateaued? What does the imaging show, right? Is it a normal spine with just arthritic spondylotic changes? Is there a fracture? Is there a disc? That may change what we do. But I think most importantly in these patients, and I think Michael brought this up too, is the comorbidities, right? I think this is really where this patient population changes, right? They're often elderly, they may have health issues, and we certainly have to factor that in when we're trying to make a decision around the appropriateness of surgery and even the timing of surgery. We've got to sort of factor that in. And so we're really looking at these patients trying to decide, okay, who in this population is going to benefit from surgery? And if we are going to do it, when should it be done? How quickly? And what else should we do to modify that, right? Should we be giving them riluzole as an example, right? Should we be putting them in the ICU and pushing their blood pressures up? Should we be mitigating any of their comorbidity issues the best we can? maybe co-managing them with another service, et cetera. So Kumar et al., they published this paper last year in the European Spine Journal, and they sort of looked at this acute traumatic score, central cord syndrome score. And I put this up not necessarily to advocate for trying to put a scoring issue out here, but it kind of looks at the key issues we're looking at here, right? What is their current neurology? What does the imaging show? Are they spondylotic or not? Do they have comorbidities? And we can use that when we factor in, surgery, urgency, et cetera, right? So if somebody's got maybe an Asia C, they've got focal cord compression, they've got no spondylosis, no comorbidities, that's probably somebody we're taking right to surgery, and we're probably trying to do that certainly less than 24 hours. Where if somebody's got, maybe an Asia D, they've got no focal cord compression, but they've got spondylosis and significant comorbidities that may prohibit them from surgery, maybe we're considering, wow, maybe this is somebody who can't undergo this operation. Or if it's a little bit less, we may, slow down, we may optimize them first, and then sort of delay things and do it in a more appropriate time. So when we look at the literature, I think some of the questions that we face, one is, again, if we go back to Schneider, they would advocate not operating on these patients. So when we look at the literature, and here's a meta-analysis from that same Kumar paper looking at just the surgical cohorts and the conservative cohorts and looking at should we operate or not. And these are pooled averages of all these studies. And again, if you look at the pooled averages, there's a greater support for surgery in these patients versus conservative therapy. So it looks like surgery does better if you look at least in a global standpoint in patients with this kind of condition compared to a conservative management, at least what's been published to date. And then we get into timing, right? And so Michael brought this up around, in all spinal cord injury patients, going less than 24 hours seems to have a favorable outcome. What about in this subset of patients? And there's been a number of systematic reviews and meta-analysis. This is a 2024 paper out of the Hopkins group with Nick Theodore looking at this, and they looked at early versus late in this condition. They had 9 studies, about 5,600 patients, and the majority were delayed surgery greater than 24 hours, but almost 40% were early. When they look at 6 months, look at the Asia scores, about same. But when they got to 12 months, they had earlier, higher total motor scores, upper and lower motor neuron scores, and those that had surgery less than 24 hours, and lower complications and lower length of stay, and they did not increase the mortality. So it looked like in their meta-analysis that those that had operated on but less than 24 hours did better with regards to their upper and lower motor neuron scores, had less complications, and we didn't see an increase in mortality. So would argue that surgery may not only be better, but you can do it and improve those outcomes in these patients if we do it earlier in this subset of patients. So again, when we look at the clinical approach, I think we treat these patients similar to our other spinal cord patients, right? So just because they're elderly, they fell from height, they have no fracture, doesn't mean we should look at them any different than we should for someone who came with a high-speed MVA and a more serious injury, right? As Michael said, time is spine. We've got to look at it the same with these patients, but we've got to consider their comorbidities, right? So can we take these patients quickly to surgery or not, right? Or do they have significant issues health-wise? And if so, can it be optimized or mitigated? And if so, let's do that quickly and then try to get them to the operating room if possible. And maybe we can't, right? It just as Chris Shaffrey talked about, taking a patient with a bad deformity to palliative care. Again, if you've got someone who just cannot undergo surgery here because the risk is too high, well, then we should not just take them. And we've got to consider that as well. So we got to consider that, consider the neurology when we're looking at timing, right? If they're improving, maybe we can hold off a little bit longer versus if they plateaued. And certainly if they're worsening, we want to get them in quickly. So early surgery has been proven to be safe, shows it has a better outcome. I mean, I think the bigger question for me is in these elderly patients is when do we go, right? So if I want to do it less than 24 hours, am I going to go in the middle of the night? Am I going to wait for the next day? You know, when is that time point for these patients? And I think it changes a little bit. And it's probably different for all of us, right? It's like, well, who is your team in the middle of the night, right? If you've got your A team that's used to doing these types of surgeries, then perhaps it's okay. But what if you don't? And what if this patient's pretty sick, right? You don't have like your A team anesthesiologist. You know, maybe it's not the most appropriate thing to take them right then and there for hyperacute surgery, as Michael talked about, but maybe put those patients on the next day, still get them within 24 hours, but optimize them and get it done safely then. Surgical approach, a little bit harder to talk about with this pathology. It's probably, with this etiology, it's probably driven a little bit more by the exact cause. You know, like in this picture here, if it's an acute herniated disc, that's probably an ACDF for this central cord patient. But, you know, more often in these patients, these elderly patients that are spondylotic, you know, this is typically more multi-level type of pathology. This is more typically aligned to our myelopathy patients, right? We're looking at doing this posteriorly, you know, classically with a laminectomy infusion, but I think we've seen a pretty good shift nowadays, certainly in our myelopathy patients, to laminoplasty. At least that's been our approach lately with somebody who does not have a fracture or instability, that a laminoplasty, at least when appropriate, may be a good operation for them. And this is sort of just extrapolated from the CSM trial, which many of us on this meeting and in person there were part of. But what it really showed in the non-randomized comparison, right? So it's a little bit biased. It's a smaller group. It was not the purpose of the study. But when you look at the non-randomized comparison of the CSM study, the laminoplasty patients actually did the best. They had the greatest improvement in SF36 compared to dorsal and ventral fusion, and the lowest complication rate. So again, it's a small group. It was biased. There's issues with this in this study, but it gives a little flavor that perhaps laminoplasty did a little bit better for CSM. And can we extrapolate that to these spondylotic central cord patients as well? And so I think we have at least tailored our approach here for those patients that are lordotic, that have just spondylosis, that have a central cord, that we've been approaching more of those with laminoplasty as opposed to a laminectomy infusion. So, you know, in conclusion, the central cord syndrome is probably the most common incomplete spinal cord injury. We're going to see this continue to increase as our population ages. It is truly heterogeneous, and we've got to accept that and consider that when we manage it. Maybe we've got to reconsider naming it, right? There's been a big push to call this, say, acute traumatic myelopathy as opposed to central cord syndrome. And maybe that changes our approach, right? When we think about central cord in Schneider's paper, we're sending these patients to rehab with a persistent injury, and we're not managing them acutely. You know, if we renamed it and everybody accepted that, you know, would that change that? I'm not sure. I think that literature that's out there has impacted some of this negatively on how we manage them and what we think about this condition. Obviously, the comorbidities really drive who's appropriate for surgery and how quickly. But certainly in patients that can go to surgery, we can do it less than 24 hours, do it safe, and probably has a better efficacy. And what surgical approach we take, we're gonna tailor that to the etiology and then really show that we can improve outcomes, decrease complications without increasing their mortality. So I want to thank you very much for inviting me to give this talk, and truly honored to be part of this world-class panel here. And again, thank you, and sorry I'm not there in person.
Very cool. I love the oversight, and again, the historical correlations to Schneider's original landmark paper, still landmark paper, are so important, and learning from that in the past. On a big picture perspective, Michael, is it true that now, knowing what we're knowing about spinal cord injuries and taking into consideration your statement that maybe this is a misnamed kind of a condition, that we should, in retrospect, take central cord injury patients out of our cervical spinal cord injury literature review because they have a very different pathoentity and prognosis?
Well, I mean, I think so, or at least change the way we look at it. Like take that maybe that nomenclature out of there, right? I think that we've been driven into that by the literature that exists, and maybe think of this as a different entity, this acute traumatic myelopathy, as a different entity. I mean, it's the same entity, but maybe we look at it differently, and that may then help us tailor our approach to these patients. And so, yeah, maybe if we can take that vernacular out of the literature, probably never can, but think about it differently going forward. I know the AO, I think, has been pushed, and Jens, you could probably comment on that. I think there's been a push from the AO to maybe try to think about renaming this and approaching it differently. I think that would be helpful as we take this forward, train new residents, new fellows, and even how we potentially create clinical trials going forward.
So insightful. Is there anything in neuroimaging that we can use to help us make up our mind how much this is an acute cord injury versus I'll just use the old term, an acute CCS? Is there a diffuser tensor imaging or something like that that we can use as a helpful hint?
Yeah, that's a great question. And I think as, DTI and other tools mature and we understand them better, yeah, we probably can. Now, I'm not sure how widespread that is, even in big academic centers, how often that's being used and even truly understanding what fiber tracts we're looking at in all these patients. But I think from an area of future research, Jens, I think it's a great idea. Perhaps we can look at that. And even looking at sort of big data models like Michael talked about and others, when we can try to look, understand, what's the prognosis of these patients? Is there a differentiation of, an ATM versus CCS patient? Does it change how we approach them? So I think the answer is yes, but I'm not sure if it's mature enough right now to really guide us on a day-to-day basis in our ERs and other centers.
I sense from you that you're fighting the same battle that we fight literally daily. My partner, Dr. Abdul Jabbar, is on call right now. We, again, had this just the other day. Aging patients who fall, if I get the statistics right, this is now the second leading cause of death in America. This basically ground level falls and the sequelae thereof, and probably unrecognized myelopathy before. Is it time that we put our heads together and educate our medical community at large better about myelopathy detection? Is it maybe important that not just having a stethoscope, but like a gate plate, like what Dr. Glassman showed so nicely with his very cool stance assessment of Romberg's test? Do we have to change how we assess patients? Should we educate them far more in terms of PT, fall prevention, stuff like that?
Oh, I think that's a great idea. Yes. I think for sure. And hopefully technology may change that, right? So now, theoretically, as somebody walks into a medical center, you're right, we can observe gait and measure gait with a variety of cameras and other, AI tools. And so, yes, education is going to be important, but I think technology may change this as well. So a good old fashioned physical exam, better knowledge of what this is and informing patients, maybe, better screening, you're right, fall prevention. And then hopefully technology will go a long way going into the future to maybe make this a little bit more automated.
Well, we loved your lecture. It was really cool and so great to see you. Thanks for being part of this educational marathon, but you're a highlight. And again, so cool to see you. And hopefully we'll have you here in the not too distant future. Thank you, Michael.
Absolutely. Thanks, Jens. Thank you.